All right, so we're going to talk about verts. When I say verts, obviously vertebral, non-vertebral fractures. And that has to do with the drugs we're going to talk about. And do we want drugs to have broad spectrum activity, that is, at vertebral as well as non-vertebral sites? So if you look at this, this is a bar graph of the kinds of fractures we see in this country, 2 million around. That's really not focused, is it? What's going on? We should make it. Yeah, that's good. Can we see better? Yeah? Okay. So there are about 2 million osteoporotic fractures per year, and you can see a good number of them, maybe half of them, are vert fractures. And again, comparing the events with the other big things in life, heart attack, stroke, breast cancer, not to minimize the importance of those disorders and those events, nor to imply that one is more serious than another. I'm not suggesting that. But just in terms of numbers, there are many more osteoporotic events in this country than there are heart attack, stroke, and breast cancer. So the vertebral fracture presents in one of two ways. It presents as an acute back pain syndrome. The grandmother is picking up her grandchild and is picking the grandchild up in the wrong way. Or someone is lifting a stuck window trying to dislodge it. Or picking up a sack of groceries and suddenly gets back pain. So this was part of a headline of the National Enquirer, which I'm sure all of you read. This is probably not true. I have no idea. But this is Liz Taylor, the late Elizabeth Taylor, who is rushed to the hospital with a broken back. Her bones are so brittle, they're crumbling. She was lying in bed, reached for something, and let out a horrifying scream. She had broken her back. She had 2 vertebral compression, according to this unsubstantiated story, 2 vertebral compression fractures, and she had vertebroplasty. Yeah, some patients could be just turning over in bed, and they can have an acute compression fracture. The more common way it presents is actually almost in an asymptomatic way or in a way that isn't recognized as an event. Do you have a thought about which is more likely? I just suggested what proportion of subjects don't have an event that is recognized as a vertebral fracture versus those who do have an event that is recognized as a, what do you think the proportion, the breakdown is? It's about 2/3, 1/3. So 2/3 are in this category. Mild pain that, not bad enough to see anybody. Found on a chest x-ray. Loss of height. And very gradual over time. So this is the late Pope John Paul II, and I don't have any information about his medical history, although I do know the doctor who took care of him. But he clearly, look at him, he clearly has severe kyphosis and likely to have had progressive compression fractures over time. So the consequences of the vertebral fracture, obviously if it's acute and clinically evident back pain. Hi, Tara. Hi. You're welcome. Thank you for this is Tara Keshanova, who's going to join us. We basically just started. But you can come or you can come back in half an hour, whatever you'd like.
Okay. I'll stay.
Okay, good. We have plenty of room, as you can see. There isn't even a chair, but you could pull up a chair.
Grab a chair.
Okay. All right. So back pain, if it's clinically evident, loss of height. In pediatrics, Rebecca, right, one of the most important elements of the physical exam is measuring height. Yeah, I mean, you'd be run out of town if you didn't measure height. In adults, you know, I measure height in everybody. And they say, doctor, what are you doing? I have a wall-mounted stadiometer. I don't use the scale thing because that's ridiculous. It's got to be calibrated so it's mounted properly. And everybody gets their height measured. And we've instructed our densitometry techs. Every room has a stadiometer. And although they're reluctant to do it, they do. So they come, the height that's reported on our bone density report is a height, not historical. This is a measured height. So loss of height, we measure height. Deformity, kyphosis, protuberant abdomen as the compression fractures push the abdominal contents forward. Reduced pulmonary function, I mentioned. Every thoracic compression fracture allegedly reduces vital capacity by as much as 9%. Diminished quality of life, you know, you don't look the way you used to. Maybe one becomes dependent on narcotics or other analgesics. Depression, loss of independence, and actually the vertebral fracture. It isn't just the hip fracture. The vertebral fracture is associated with increased mortality. But they get no respect. And here are several examples of the no respect the vertebral fracture doesn't get. So this is a very interesting study from France that looked at the x-rays, just a routine set of x-rays, about 1,000 women, just hospitalized for a bunch of different things, and a chest x-ray was done. And then they reviewed the lateral chest, and they found, I believe, 126 compression fractures on review of those x-rays. And then they looked at the report, and they found only 52% of the radiology readings had noted a compression fracture. Half of those, or only 23% of the total, had it carried into the summary, compression fracture, T11 or what have you. 17% had actually had eventually a diagnosis of osteoporosis, and only 5% had been treated. Now, this was an old study, but it's not that old in terms of what it's telling us. We still have a problem identifying the vertebral fracture. The vertebral fracture is either a clinical event or, as I mentioned, could be an incidental x-ray finding. 2/3 of vertebral fractures are found on x-ray and not occasioned by a clinical event that is recognized. Now, on the other hand, a non-vertebral fracture is virtually always a clinical event. Most people who break their hip know that they have broken their hip. Most people who have a Colles fracture know that they've had it. So we have a distinction in terms of the clinical presentation. The non-verts are almost always an event, and Tara will tell us all about the non-vert hip fracture that we see in the hospital, while the vertebral may or may not be. Okay? So in terms of hip fractures, we have somewhere between 200,000 and 300,000 hip fractures. We actually distinguish the hip fracture. It's obviously a non-vertebral fracture, but we kind of isolate the hip fracture because it is, in a way, the most important of the fractures we deal with. So sometimes we say, you know, other non-vertebral fractures. So to be actually clear, obviously a hip is a non-vertebral fracture. And I think you've seen this kind of unfortunate data, the mortality figures after 1 year, disability after 1 year, unable to walk independently, and an inability to carry out at least one activity of daily living, up to 80%. So it is really a morbid event. It's an event that increases mortality. So the totality of the non-vert fractures include hip and, of course, many of the other sites that we are very familiar with. So what are non-vertebral fractures? They're literally any fracture that isn't a vertebral fracture. Now, they're not all due to osteoporosis. And then this whole issue of trauma gets us all bollocksed up, because a traumatic fracture is technically not a fragility fracture. But it's now becoming blurred because, as I mentioned last week, yeah, you had a traumatic event, but why did you fracture? Or why did your patient fracture when somebody else subjected to the same force, given a traumatic force, might not fracture? So maybe there is something that predisposes somebody to have a fracture, even though she experienced a traumatic event. Although technically, if it is a traumatic event and the fracture follows, we don't recognize it as a fragility fracture. Now, if you look at clinical trials, and we're going to talk about clinical trials, and they're divided into vertebral fractures, hip fractures, and non-vertebral fractures. And what do we mean by, from the clinical trial definition, what a non-vertebral fracture is? So on the left, all clinical trials will include upper limb, clavicle, humerus, forearm fractures, pelvis fractures, and lower limb, obviously, femur, hip, and lower leg. So these are the big 6 fractures when we say non-vert. Clinical trials talk about that. Now, the middle column, it's iffy. You know, sometimes they do, sometimes they don't. Most of the times they don't. Rib fractures, scapular fractures, sternum fractures, sacral. Can you imagine? I mean, a sternum fracture, how can a sternum fracture be a fragility fracture? Hard to imagine. But anyway. And then on the right, we always exclude, as a non-vert fracture for the purposes of a clinical trial, skull fractures. Obviously, a skull fracture, by definition, has got to be a traumatic event. Someone has to hit you over the head with a hammer. I mean, you know, really traumatic. Fingers and toes. We see a lot of digit fractures. And I had just a patient last week who said, "Doctor, I had to tell you, I broke my little pinky, my little baby toe. I banged into something, and the drug isn't working." Well, you have to reassure them, no, we don't count the baby toe. We don't count the pinky. We don't count digit fractures. They occur, but they're excluded. Okay? So, 3 important points about bone density at non-vertebral sites and about non-vertebral fractures. 1, reduction in bone density at non-vertebral sites predict non-vertebral fractures. That's the same. There's nothing different about reduced bone density at non-vertebral sites. They're just as predictive as a reduction in bone density as at a vertebral site. A non-vertebral fracture predicts another non-vertebral fracture. There's nothing fancy about that comment either. And a non-vertebral fracture predicts a vertebral fracture. The point is that fractures predict fractures. Non-verts predict verts, verts predict non-verts. We don't make a distinction clinically as to the predictive value of a fracture that's occurred, either a vertebral site or a non-vertebral site. Like vertebral fractures, non-vertebral fractures don't get any respect either. So we don't recognize it. Fractures occur in subjects not known to have osteoporosis. If the fracture is a fragility fracture, the diagnosis is osteoporosis. The logical next steps are to further evaluate the patient and take measures to prevent the next one. That's sort of so obvious. It defies the need to even talk about it. But that event, that sentinel event, is not being recognized. So here are studies way back 15 years ago that unfortunately demonstrate that then and now. And this has to do with the distal radial fracture that occurred. And this follow-up study looked at the percentage of individuals who had either received a diagnostic evaluation both evaluation and treatment or simply were treated. And this pie graph indicates that only about 25% of those who had had a distal radial fracture had been evaluated and or treated, as opposed to 75% who had not had anything done to them except treatment orthopedically for their distal radial fracture. And this one you've already seen. This is the vertebral fracture. So the majority of patients are not treated after a fragility fracture. These are from data from the HEDIS measure. These are quality of care measures that various specialties have to meet. And this just unfortunately compares very recently the standards of care for heart attacks, breast cancer screening, and osteoporosis. So beta blocker use after 6 months after, for 6 months after a heart attack, 90% is standard of care. Everybody gets a beta blocker after a heart attack. Breast cancer screening greater than 1 mammogram in the past 2 years. That's part of all of the preventive indices of care, 71%. And osteoporosis testing treatment after a fracture, 29%. And this has been the case since people started to look at this. So I showed you old data, I'm showing you new data, and it isn't just the United States, this is an international problem throughout the world. So, secondary fracture prevention, when we say, when the T-score is not a T-score, is not a T-score. Forget the T-score. A prior fragility fracture is the most powerful risk factor for additional fractures, and it is completely independent of the T-score. And we say a fracture begets a fracture, begets a fracture. It's a house of cards. Once one falls, all the others are going to follow through. Bob Lindsay published his very important paper years ago pointing out the point I just made. The number of vertebral fractures at baseline and the incidence of new vertebral fractures at 1 year. In this particular group of 3,000 women or so, as part of a study, 0 fractures, there was some incidence. If the person had had 1 vertebral fracture at baseline, you can see it almost doubles. If that person had more than 1 or more than 2, you can see that the more you have a history or evidence for fractures singly or multiply, that makes your risk even greater. And if you look at this from the point of view of the severity of the vertebral fracture, and you can do that by quantitating the vertebral height, Harry Janan's semi-quantitative method gives you tertiles of mild, moderate, and severe. Severe would be greater than 40% loss of vertebral height. The worse the fracture itself, and this is a scale of 10, for a single fracture, the greater the chance of another fracture. So the worse the fracture, the greater the chance. So, getting back to what we think. A patient came to me last September and she said, "Doctor, if you had fallen the way I fell, you too would have broken your arm." You've heard this, right? And the patient's husband, who was with her, said, "Doctor, she's right. She just tripped and fell." So there's a perception issue here. She didn't have a traumatic fracture. She tripped and fell, and she broke her arm. So the patient says, anybody would have had this. And the husband says, no, well, she just tripped. So how do we take the right next steps after the first osteoporotic fracture? And this introduces the topic of the fracture liaison services. Why we need an FLS, that's what we call the fracture liaison service. Well, we have a problem with our brethren, the orthopedic surgeons. They are not, it's not their job. They fix broken bones and this and that. By the way, at the National Osteoporosis Foundation meeting, Tara, you'd be interested in this, there were, I don't know how many registrants, 400 or 500 registrants. The predominant specialty group were orthopedic surgeons, which is amazing, truly amazing, and good news, because typically at an osteoporosis meeting, you don't see orthopedic surgeons. But they were the biggest group that was there in Miami. Primary care physicians don't usually do this unless advised by orthopedics and may not see the patient. So primary care physicians they're a little bit tangential, unfortunately. Osteoporosis specialists usually don't see the patient during the fracture episode because the orthopedic surgeon hasn't, the mindset, oh, gee, this may be a fragility fracture. We should call the endocrinologist. We should call somebody to get the process moving. And as a result, the patient goes home to have her next fracture. So the idea is that fracture liaison services can make a difference. These programs are in-hospital, outpatient. The goal is to identify, evaluate, and treat patients with fragility fractures, to coordinate care among the specialties, and you can't just do it unless you have an organization. And then there are several initiatives. These are some of them. The IOF has a program called Capture the Fracture. The NBHI has it's a very active consortium of societies, and they have an initiative called Fracture Prevention Central. The American Orthopedic Association actually has a program called Own the Bone. And here we have a fracture liaison service. Dr. Cyrus is the head of it, and Tara, who just came in, is going to take over now and tell you about FLS. Let me make one more comment before I introduce Tara. And I made this comment we had 5 cases to discuss, and it had to do with a patient who had a fracture and was completely neglected and went home to have another fracture. So I made a personal comment about our program, and I said that Dr. Cyrus had been trying to get this set up. She went to the Department of Medicine. The Department of Medicine said, this is an excellent idea, but we don't have any money to hire anybody. We went to the hospital. The hospital said, this is a really excellent idea, even as she threatened that the HEDIS measures would call them to task if they didn't have a certain percentage of such fractures attended to in this way. The hospital said, thank you very much, but we don't have any money. Then she went to the orthopedic department. And the orthopedic department said, sounds like a really good idea, but we're also poor. So it was only through the gratitude of one of Dr. Cyrus's patients who she talked to about the FLS. And this patient said, we need this here. So she has given us a grant to pay the full-time salary for Tyra. That's why Tyra's here. Thanks to a patient who, and only she, despite all the needs we have. And if you go around the country, you're going to hear the same kind of story. So how many of you do you have FLS in your medical center? Molly, you have one. Mohammed, you have one. Yeah? 3 of you. That's it. 25% of the group. So that's the issue. We need FLSs. And we have one here. Tara, you've been here for 2 years?
Yes.
2 full years.
Yes, 2 years exactly today.
Today. It's great. Yay. And Tara, so we interviewed a few people for the position, and you captivated all of us because of her, and you'll see why. You need to have somebody who understands what's going on, has great enthusiasm, and a certain amount of, I can do it myself, I can talk to these doctors, I can get them to understand, and I have no fear. I'm not going to be intimidated by the doctor with a white coat. This is something very important. Tara has all those qualities, and she's going to tell you now about what we've been doing here for the past 2 years. Before you start, are you going to add the Rich Goodell's slide? Are you going to go over those slides?
Yeah, I can.
Because I put them on at the end.
Okay, I can do it, or you can do it just now.
Well, we'll see how it goes. But we just added a few slides yesterday to complete the presentation. So Tara, take it over. All right. What I thought, just as a follow-up, Tara mentioned the closed systems, and I thought you might want to know because there is a literature now on FLSs, And the most impressive relates to the Southern California Kaiser system. This program has been led by Dr. Richard Dell, who is an orthopedic surgeon. And so they started years ago. They were way ahead of all of us. And the goal was, again, to address the care gaps. And they had a very committed team, a process by which they would, again, as Tara mentioned, identify the patient and get them to be evaluated and to have a way of evaluating the progress. I don't know what the incentive-based versus punishment for achieving goals had to do with it. But it was launched in 2002, again, primarily an orthopedic surgeon initiative. So this is quite unusual. The goal was to reduce hip fracture rate by 25% and to collate the data so that they could actually prove that their steps had a positive outcome. So this was the 7-year experience. There was a 5-fold increase in the use of DEXA from 2002 to 2009. There was a 3.5-fold increase in the initiation of treatment based upon identifying the patient and getting them into treatment programs. And then there was a 50% reduction in the incidence of hip fracture, along with this, not just the savings of all this money, but savings in terms of mortality. This is the number of patients over time who are on osteoporosis treatment. Men are in yellow, the women are in the blue, and the total is in the lighter color. So you can see how much this program brought people into a treatment regimen. And this was the adherence versus with regard to the outcome of hip fracture. So they have all the demographics, and they have an expected incidence of hip fractures in the blue, and the yellow is what they actually saw after they implemented this system. And you can see that at any of the ages, the system worked. It reduced the expected incidence of hip fractures by a lot. So it is a system that can work. It does require, though, a commitment in terms of personnel, funds, but again, you get the money back. You get the money in terms of the savings in the end. Okay, now let's go on to a discussion of, we talked about bone density, and I'd like to now talk about other bone qualities. And again, this is a little bit of an introduction. Tomorrow, David Dempster will talk a lot about this. But when we talk about other, well, let me go back just for a moment. This slide used to say bone density plus bone quality equals bone strength. And I changed this years ago because bone density is a bone quality. And so we should talk about the other bone qualities. And those are listed here. And we're going to touch on some of them. For example, bone remodeling. This is the bone remodeling unit. This is the classic sequence by which a divot of bone is remodeled. That divot of bone is eaten away by those multinucleated giant cells called osteoclasts. We really don't know what the signals are that activate the osteoclast to get it to literally create the bone remodeling unit. But that process takes anywhere from 3 to 5 weeks, following which these mononuclear cells, the osteoblasts, come in, they fill in that divot of bone with type 1 collagen, and over a 3 to 5 month period, that collagen is mineralized. And at the end of the day, you have restored the bone remodeling unit. Now, this is not obviously an example of someone who's in normal bone balance. This is an example of someone who's in negative bone balance. At the end of this 5-month remodeling period, there's less bone in this bottom cartoon than there was at the top. And that's because there was either too much bone resorption so that the osteoblast couldn't fill in the hole, or there was not too much bone resorption, but there was inadequate bone formation to make up, or more likely, a combination of both, that the osteoclast is hyperactive, and the osteoblast is not capable. But this is unbalanced bone remodeling, and this is at the essence of bone loss, virtually for any reason. And as you can see by this cartoon, the more you have bone remodeling units, the greater the rate of adult skeletal loss. Because if each unit is a negative experience, if you have many, you're going to have more. The fewer of these units, the better it is. And bone turnover in the middle has been shown by Patrick Garnero years ago to be an independent predictor of fracture risk. If you have low bone density and high bone turnover together, they're additive. So the bad combination is somebody who has low bone density and you do bone turnover markers and they're high, that person is at greater risk than someone who has low bone density and normal bone turnover.
How do they define the high bone turnover? Was it above the normal, above the reference range, or in the high normal?
Yeah, well, there are normal ranges by age, and how you define it, you could be very strict and say, if it's above normal, whatever that normal range is, that's high bone turnover. I don't wait until the bone turnover marker, because the range is very broad, particularly bone resorption. So if you wait until the CTX in some age group is over 1100, you're never going to see it. So, I mean, you kind of have a sense if the CTX is over 600. So, but that's still technically within the normal range. So here's the some birth to older age idea. In children, of course, you're not remodeling, but you're modeling. The child really doesn't remodel very much unless they break a bone. So you should be in a positive mode with formation being greater than resorption. And then you get to this kind of equivalent zone where you're neither gaining or losing, and at some point this may be a little bit inaccurate, although some people have said it starts at 35, but it does happen before the menopause. We don't know how much before the menopause. Resorption begins to exceed formation, and then certainly in the menopausal years you have resorption exceeding formation, and then depending on what kind of skeletal metabolism we're dealing with, you could be in a high resorption turnover state, you could be in a low turnover state. So it really isn't clear, but age-related bone loss would, again, be imbalanced in favor of bone resorption over bone formation. So what is wrong with bone turnover? I mentioned you're going to lose bone mass because each of those bone remodeling units is a negative experience. But there's another point, and it's a biomechanical point. You can see those little units in the bottom, and those are points of vulnerability. Those units are not mechanically competent. It's bone that's been dug up, and there's either no bone there at the time or immature bone that hasn't yet been mineralized. So these little areas, these bone remodeling areas, are called stress risers. They're points of where stress gets concentrated and can lead to breakage. That may well be the case. So the high bone turnover state is not just going to lead to low bone density, but it is going to be itself a risk factor for fracture because you have points in bone that are weak by virtue of being remodeled. So again, high bone turnover is bad for that reason as well. Now, how do we monitor bone turnover? We have bone resorption markers and we have bone formation markers. And I've highlighted the ones that we are typically using these days. The urinary NTX which is a peptide of type 1 collagen that gets cleaved when collagen gets metabolized. The urinary NTX seems to be pretty good. I believe that the fasting serum CTX is more accurate. It's a more expensive test, and it's not always covered, so you have to know whether it is going to be covered or not. If you can get the fasting CTX, I would advise that that's better. And on the right, bone formation markers. The bone-specific alkaline phosphatase is very easy to get. And of all these markers, the bone-specific alkaline phosphatase is the least likely to be affected by renal failure. So if you have a patient with type 3 or worse CKD, and you want to get a marker of bone metabolism, the bone-specific alkaline phosphatase is better. Osteocalcin. And P1NP is available, and we don't have as much experience with P1NP as a bone formation marker. Now, it's very controversial as to whether or not people like to use bone turnover markers. At this meeting in Miami, I said, yay, I like bone turnover. I like bone turnover markers. I think they give me information. My colleagues, who are also experts, said, very misleading. They're not reproducible. The precision isn't great. And they don't necessarily reflect what's happening in bone. These are circulating markers. And so how do we know that they correlate? Well, they do, but it's in the kind of correlative way that one can't be absolutely sure. So I'm not here to say they're great, but they are useful. And they do help complete my thinking about somebody and whether or not they're in a high turnover state, a low turnover state, and that might also influence, not always, the choice of the treatment that I select. So, what about microstructure? A disease of compromised bone strength. And when we talk about bone strength, we get well beyond bone density. We get into the microstructure of bone. I'm showing this, another example from David Dempster's collection. But now I want to show it to you a very important element of the topology of the microstructure. It isn't just reduced or compromised microstructure, but in osteoporosis, there's a specific orientation that's abnormal. And the arrows indicate what that is. The horizontal struts, the ones that go crosswise, are the ones that are the strongest, the ones that keep your bones as strong as they can be, in contrast to the vertical struts that are not nearly as effective. And let me give you an example of what I'm talking about. This is a suspension bridge. The point about the suspension bridge, or the three-legged stool with the crossbar here, is that the strength of the stool or the strength of the bridge is not seen in those vertical struts, the two stanchions of the bridge. It's the suspension that's literally holding up the roadway or giving that stool stability. If you knock that crossbar off that stool, you'd have a very unstable stool. There's nothing wrong with the vertical strut, it's just not competent because it's not linked. And that's kind of the idea. In osteoporosis, these horizontal struts that are literally holding up bone are dropping out. And there's an old theorem about this, Euler's theorem, that says the strength of the bone or any structure is a function of the distance between the effective cross length of the strut. So for example, if you shorten the effective length of the strut by these crossbars, you actually strengthen this bone much more than you would if you just had a pipe or a bone that had none of those crossbars. And they talk about buckling load and supported trabeculae, unsupported trabeculae. But on the left is what you want to see. You want to see a finely articulated network of bone that is strengthened by these horizontal the horizontal system. And in osteoporosis, we see, unfortunately, more on the right than on the left. So this was our first 1.0 version, and can't tell the difference between the 2.0. This is Serge Kremers, who you're going to see this afternoon. He volunteered to be shown having his arm measured. This is a very simple test. It takes all of 3 minutes. You have to keep your arm absolutely still, and then you put your leg in the machine, and we have a little Velcro cuff to keep your leg stable. I had my HRPQCT, and I moved. And I failed, and I had to be retested. But this is the non-invasive gold standard by which we can measure microstructure in patients or in terms of a research study. And this is an example of how extreme CT it can tell you what's going on. This on the left is a normal person. Middle is someone who had low bone density. On the right, you have somebody who has had a hip fracture. And you can see on the right the cortical porosity in contrast to the other cortices. And the inner part, the trabecular compartment, is literally, it's terrible. So we can see this by non-invasive microstructure. And then finally, we're going to talk about mineralization of bone. So you have bone mineral that gets deposited in the interstices of the type 1 collagen. And there is a period of bone mineralization where there's more or less mineral in a given unit of area of that bone. And here's an example of Alendronate, one drug we're going to talk about, where the green is the Alendronate, and you can see that the mineralization curve is shifted to the right, suggesting that Alendronate is improving the mineralization, how much bone mineral there is per unit volume of bone. This is not an easy test. It's a research test, and it's only done in research setting. But mineralization of bone can also be a point that improves bone strength. Okay, so let's move on to approaches to osteoporosis. Now we're talking about treatment. And these are the non-pharmacological approaches. And I'd like to make a couple of comments about some of these points. So calcium. The recommendations are that we take in between 1,000 and 1,200 milligrams from all sources. And obviously the major source of dietary calcium is dairy. We use calcium supplements to supplement the difference between the amount we take in our foods, including calcium supplemented foods, and what is needed. So the 1,000 to 1,200 milligrams of calcium is the total amount, not the amount you would give in a supplement. And in terms of the efficiency absorption, we advise no more than 500 or 600 milligrams of supplemental calcium at a time. Beyond that, the efficiency of absorption falls off. And we also recommend that the calcium be taken with food, preferably a protein-based meal, because of an added benefit of protein when it comes to calcium absorption. Now, the forms of calcium we use clinically are calcium carbonate. 40% of calcium carbonate is calcium, or calcium citrate. 20% of calcium citrate is calcium. Why we advise calcium carbonate more than calcium citrate is because you can get more calcium in, because of the percentage of calcium carbonate that is calcium. Now, calcium carbonate requires a source of acid for absorption. And it comes either from gastric acid or from food. And the source of food acid is protein. Protein is acidic. And I mentioned that may be one reason why absorption is enhanced with food. Now, some people think that calcium carbonate causes gas, bloating, and constipation. You hear this a lot. Actually, it's never been documented, and it's been looked to see whether or not calcium carbonate does have those negative features. Whether it has been shown or not, patients will complain. The alternative is calcium citrate. Calcium citrate does not require acid for absorption. It is also enhanced with food, so there may be something else about food besides being an acidic load. And I have to say myself that patients have told me when I switch from the carbonate to the citrate that those GI issues are lessened. So there is some experience here that calcium citrate is better tolerated. There are many, many brands of calcium carbonate and citrate. You go to the local Rite Aid or CVS, and it's bewildering, the number of varying products. And you have the branded calciums and the non-branded calciums, the organics, the this and that. And these pills are very hard, by the way. If you've taken a look at one of these pills, very hard. And there is an easy way to tell whether or not these calcium pills provide bioavailable calcium. And it doesn't matter whether it's generic or branded. You want your calcium pill to be bioavailable. My wife has said that we Americans have the most expensive urine. You know, some of these bottles are $100. You know, $100 for nothing. Gets peed out. So there is an easy way of doing this. And I told the patient once, all right, you take your calcium pill and you put it in half a glass of vinegar. Vinegar is acetic acid. And it should dissolve. 2 or 3 minutes, it should dissolve. And if it dissolves, you can be pretty sure that it'll dissolve in your stomach, because your stomach is hydrochloric acid. It's even a stronger acid. That is actually true. You put you test it yourself. But the thing I forgot to tell the patient, and she comes to me, she said, "Doctor, you're absolutely right. The calcium pill dissolved, but you didn't tell me it was going to taste so bad." Some patients do exactly what you tell them. So, but it's a good little bioavailable test. All right. So, yeah. Hold that one. Hold. We're getting there. Very good. I knew you were going to ask that question, so I will address it in a second. So calcium, 1,000 to 1,200. This is the Institute of Medicine. And under the age of 70, we talked about this last week. 600 units, that's up from 400. And over the age of 70, 800 units is recommended as a minimal nutrient requirement. Now, just so you understand the controversy about calcium, let's understand that calcium is a threshold nutrient. That means that for a certain amount of intake, there will be better calcium retention, calcium balance, up to a point, beyond which further calcium is not going to give you any better benefits. And this is Bob Heaney's work, who has clearly shown that for calcium, you reach a value. It is a little bit dependent on race and such. For example, Asian women in Hong Kong have been shown to reach this plateau much earlier. But in this country, it would seem like this threshold is reached somewhere around 1,500. So if your patient is taking more than 1,500 milligrams of calcium from all sources, you're not getting any benefit. And the IOM recommends that the limit be no more than 2.5 grams or 2,500, beyond which there may be an increased risk of kidney stones. But there's no point. There's no point in taking all that much calcium. You're not getting any benefit. And if you read the literature on the alleged cardiovascular effects of calcium, those studies have been plagued by a lot of real experimental design issues. And they did not pay attention to whether they were talking about amounts of calcium that were exceeding this threshold nutrient or ones that weren't. But the field has really come to accept, with some outlier investigators who continue to write polemics in the New York Times and elsewhere, that calcium in moderation, the way we use calcium, is not bad for any part of you. Not bad for your brain, not bad for your cardiovascular system, and is good for your bones. And if you're calcium deficient, or whatever else you might do, you're not going to maximize the benefits of whatever else you do. So there is a minimal daily requirement, and again, Bob Heaney's work suggested that it's around 1,500. And above this, it's going to go right out. You're not going to gain any benefit. So, how'd you know I was coming to this? So what do you think about these statements? Magnesium sufficiency is required for optimal calcium absorption from the gastrointestinal tract. True or false? How many of you say true? A majority of you. How many of you say false? A couple of you. Okay. The answer is true. Okay. You need to be magnesium sufficient to optimally absorb calcium from the GI tract. Another statement. Magnesium has to be in the calcium pill for the calcium to be absorbed optimally. True or false? True? False? Good. Got it. But this is a common misunderstanding. Many calcium preps have magnesium, and patients say to me, well, doctor, you didn't tell me anything about magnesium. Shouldn't the calcium pill have magnesium? And I say, well, I know the patient doesn't have any obvious gastrointestinal problem. There's no malabsorption issue here. The person's on a regular diet, is eating vegetables, a very good source of magnesium. So it's very, very difficult to become magnesium deficient. I mentioned last week, if you're an alcoholic, you can dump magnesium in the kidney and you could be malabsorbing. But short of that, the normal, regular person who doesn't have a gastrointestinal problem, is on a regular diet, will be magnesium sufficient. And that's what you need. But the magnesium doesn't have to be in the pill. Now, why might you recommend the magnesium to be in the pill? Yeah. So it is the opposite. If calcium is constipating, we know that magnesium is not constipating. And in fact, magnesium is a cathartic. It can be used as a cathartic. So some people find that the calcium magnesium pill helps in that regard. But again, just to understand what we think about magnesium, it's in that way. All right. Other non-pharmacological recommendations. Exercise, we've talked about exercise. Everybody wants weight-bearing exercise. And weight-bearing exercise is just standing on your 2 feet like I am, and walking, running. We don't have many patients who run, but some of our patients may jog or do fast walking. Pulley-type training exercises, iron pumping, some people like to do. I like to have patients put a little Velcro cuff around their wrists with putting in 1, 2, or maybe 3 pounds of weight, because the arms really are weightless. When you walk, your arms are kind of flapping. That's the only part of your skeletal system that is not weight-bearing when you're walking. So putting a little bit of weight on your arms can sometimes be helpful. But on the other hand, suppose you had a patient who swims. And she says, doctor, I've heard that swimming is not good for my bones. Should I stop swimming? What kind of advice would you give her?
Not if that's the only thing she can do. Not if that's the only thing she can do.
Well, suppose she can do something else. Suppose she said, I love to swim though. Swim. But so what I'm trying to get at is, why have her stop doing what she really likes to do? There's nothing wrong with swimming. Swimming is a cardiovascular exercise, you know. Somebody who can swim. Did I tell you last week of this patient I saw? I can't believe this. I'm still musing about this. He's 80 years old. He tells me he swims 1.2 miles in 35 minutes. Can't believe that. But whatever, I told him to keep swimming. Keep swimming. Yeah, because it's cardiovascular. And he's fit. He's really fit. So that is good. If you're fit, you're feeding every part of your body with oxygen. That's the definition of fitness, your ability to utilize oxygen. And your bones are being fed too, just like your brain. So I don't have a problem. And nobody has really shown that swimming is bad for your bones. Maybe it doesn't accrue bone, but we know that bone doesn't accrue in adults anyway with exercise, just in children. So I think it's not a major discussion whether it's weight-bearing or not, although weight-bearing does get the nod. Yeah, Molly?
Sorry, the woman who presented at the bone rounds on Thursday says she sees a fair amount of low bone density in bikers. There is some literature on that. Admittedly, I don't understand it because you don't either, I'm sure. Because biking, you're pedaling. It seems to me, but it's curious because there is a literature on bicycling. But on the other hand, I don't discourage somebody from bicycling. If they want to bicycle, they can bicycle. Yeah. So it's a very interesting literature, but there is a literature on that, and I don't know why. Tai Chi, yeah.
I know this is an odd question, but does posture contribute at all to any reduced bone density, maybe with biking and things like that?
Yeah, that has been, it's odd. I didn't mention that, but that has been, so a biker is leaning forward, and is that, I don't understand that. So, but it's not, you're not permanently like this. So I don't get the posture argument, but that has been advanced.
But posture does contribute potentially to lower bone density, or not? You've never
It shouldn't. It shouldn't. But there are lots of people with poor posture, but it doesn't, but yeah.
So you were just saying that with swimming, like even as an adult, you're not in like an active formation state, so it probably doesn't make a difference. What if you have a pediatric patient that's like a competitive swimmer, for instance, and like only does swimming? Would you recommend in like the pediatric population that you don't exclusively do swimming because you are concerned about actual inflammation?
Yeah, I don't know. I can't answer that. You've watched competitive swimmers. They're not frail people. These are really very strong people. I mean, they're amazingly strong and fit, and you just look at them. So I don't buy that. I mean, in the pediatric population, I'm not really that aware of that exercise and what the data are in the pediatric.
I don't think it exists.
I don't, so my thought is, is you can't be bad for them. Can't be bad for them. Tai Chi. We talked about Tai Chi. So Tai Chi is not going to make your bones stronger, it's going to improve your balance. And that's probably why Tai Chi is said to be good, and it probably is. So if someone's doing Tai Chi, there's nothing wrong with Tai Chi. Okay. Smoking cessation, we don't have to, yeah.
With patients with osteoporosis, especially in the spine, sometimes they ask you if there's something that they should limit. I have patients that ask about yoga or like Pilates. I don't know if you tell them to take it like slower for this.
Yeah, well, so again, here's the idea. If they're doing yoga or Pilates, some of the yoga, I'm not a yoga person, but the yoga exercises are almost contortions. You keep them away from that. But simple ABC yoga and similarly Pilates should not be a problem. But you get to the advanced levels, and then again, depending on the patient, you may discourage that. But some of the yoga exercises are probably not to be advised. Okay. Smoking is bad for everything. You all know that. There's just no justification for smoking. I mean, I can't come up with do you have if you were to argue against the grain, is smoking good for anything? Well, I was wondering if somebody's going to say that. So, yeah, and well, no. The answer is no. But So ulcerative colitis was touted as a disorder for which smoking was really good. I had a patient who was going to have a colectomy. He had been a smoker, and he had stopped smoking, and his colitis flared, and he was actually on the op schedule. And he said, what the hell, I will take up smoking, you know? And the colitis just went into remission and such. And you hear that. But there was a study, a very good study that was published in the New England Journal that did have a control group, and I believe that study still stands. It was shown quite definitively that smoking did not improve ulcerative colitis. But that used to be the exception. Am I wrong about that? Are we still thinking that it's, because that paper is very old. It's because we're at least 10 years old. Anyway, the point is, it's not good. Alcohol, we talked about last week, in moderation. Alcohol is good. But in excess, it isn't. I don't, by the way, tell my patients to start drinking alcohol. I don't do that. But if they are drinking alcohol, I don't discourage them. And then my patients who, I have a number of patients who have it as a disease. They have alcoholism. And obviously, they must avoid alcohol. But it's a discussion that you might have with your patients who might feel embarrassed by telling you that they drink alcohol. I have a lot of patients say, well, I only have a little drink every once in a while. It's okay. You can tell me. I'm not going to tell you no. But people feel defensive when they don't necessarily have to be. And then fall prevention is a whole area that we don't discuss enough. But if, again, as I said, if you can prevent the fall, I don't think it doesn't have anything to do with the bone density or any other risk factors for osteoporosis, that patient is not going to break her hip. 95% of the falls, 95% of the hip fractures occur after the fall, not before the fall. So again, if there's something we can do about fall prevention, and some of our older patients who are living alone and their apartments or their homes are accidents waiting to happen. There are scatter rugs that scatter. They don't have railings in the bathroom and such. Wires here and there, things to go in to help. In family medicine, there used to be, I don't know now, but one of the parts of the residency in family medicine would be to go visit, home visits, and actually look into the homes and see these older folks and just try to maximize the safety of their environment, something that we probably should do more. So this is a table that is very useful, I think, because it presents the drugs that, and we're not going to talk about all these drugs, but it presents the drugs that are generally available either here or elsewhere in the world, like strontium. And it gives you a sense of the efficacy of the drugs. And you'll notice that all the drugs in the left-hand column of vertebral get pluses. And that is obvious because the FDA will not approve a drug for osteoporosis unless you have vertebral fracture efficacy. So it's a given. Now, when you get to non-vert and hip, however, you don't see pluses across the board. Estrogen, alendronate, risedronate, zoledronic acid. So 3 of the 4 bisphosphonates have evidence, and good evidence, for broad spectrum efficacy, with abandronate being the outlier. Estrogen, by the way, the pluses relate to the Women's Health Initiative. The negative comment about the Women's Health Initiative is that those women did not necessarily have osteoporosis. It wasn't a study, the idea wasn't, it wasn't an osteoporosis study. It was a study of women, and it did show that there was efficacy across the board. So if it works in women who don't have osteoporosis, the assumption is that it would work if we had the data in women who did. I will talk about abandronate later. Denosumab, pluses across the board. Strontium, we're not going to talk about. Raloxifene, calcitonin, only pluses for vertebral. And teriparatide, gets pluses for vertebral and non-vert. We don't have the evidence. Now, the negatives, the little dashes there, don't misunderstand what I mean by negatives. I don't mean that the drugs have been shown not to be efficacious. I mean that the drugs haven't been shown to be efficacious. So if the data are not there, it doesn't mean the drugs don't work. It may mean because of the experimental design. For example, teriparatide, that study was relatively small, only 1,672 subjects. It was foreshortened because of the animal toxicity that we'll talk about. So at the end of only 19 months, with only 1,200 patients, the study could not have been powered to have been able to show that the drug was efficacious in terms of hip fracture. Okay? Now, what's happening? Maybe it's because it's 11 o'clock. What is happening? I don't know. Escape usually gets us out of here. I don't want to do. The anti-resorptives, this is a category. Some people call them anti-remodeling. I like to call them anti-resorptives. They improve bone strength, and their primary mechanism of action ultimately is to reduce bone turnover. There are different ways they reduce bone turnover, and we will talk about that. But by reducing bone turnover, they stabilize microstructure, they improve mineralization, and secondarily, they improve bone density. Bone density is our major surrogate marker of efficacy. And if it doesn't improve bone density, the drug doesn't lead to a reduction in bone density. And the original drug is Alendronate. And the drug works this way. On the left, it initially reduces bone resorption. Since resorption and formation are generally linked, if you stimulate one, you're going to stimulate the other. If you inhibit one, you're going to inhibit the other. There is a subsequent reduction in bone formation, never quite to the same level until you get way out as you have with resorption. And so you're altering the balance because you're inhibiting resorption more than you're inhibiting formation. And the net result on the right is an improvement in bone density. Now, typically, with these drugs, the lumbar spine improves first and most. The hip improves a little bit more slowly, and never, almost never, hardly ever, does the hip density change as much as the back density. And for those of you who measure the arm density, it's even slower if there's any change whatsoever. Typically, the arm density doesn't change at all. So what could explain this? And it's important for you to know because patients are aware. They look at their hip density and say, oh, doctor, it's only moved by 1 or 2%. And the back is, fantastic. What's wrong with this drug? So why do we see this typical pattern? Sorry?
Because of the trabecular bone being more active.
Good, good. Yeah, so it's the metabolism. Trabecular bone turns over 15% per year, and cortical bone turns over 1% per year. So you're always going to see an effect at the site that is most responsive because it's being metabolized much more rapidly. So that is the explanation. All right. So all of these anti-resorptives, as I mentioned, reduce the risk of vertebral fracture. Estrogen, as I mentioned, this is from the Women's Health Initiative, reduces either its conjugated estrogen alone or progestational. The reduction of clinical fractures is pretty clear, and most of those clinical fractures were non-vertebral fractures. And the WHI showed that there was a 34% reduction in hip fracture. Pretty impressive. But the problem with estrogen, as you all know, are issues related to the cardiovascular system, breast cancer, venous thromboembolic events. Marjorie Gass presented on Saturday. Marjorie Gass was the principal investigator of the Women's Health Initiative. She's fabulous. And Marjorie gave a wonderful talk on this whole subject. She focused on bone, but she touched on these other points. And I asked her, because she didn't really make the comment, I asked her, what about the women who transition from menopause directly into HRT, the women for whom there aren't any contraindications? Do you see the same increased incidence in the women who immediately go in as opposed to the women who started estrogen 10 years later? And many of the women in the Women's Health Initiative had not seen estrogen for 10 years. And she agreed with the data, which says that there is much less of a concern, at least for the first 10 years, in women who transition directly from the menopause to HRT. But nevertheless, it's time dependent, and these things become more evident with time. So those are small things. But because of all of these issues, estrogen is not used as a primary therapy to prevent bone loss, and it is not a use for the treatment of established osteoporosis. The only indication the FDA gives is for the prevention. So you can use estrogen. It's maybe not the primary therapy, but it does have an indication for the prevention of bone loss, but not for the treatment of osteoporosis. The selective estrogen receptor modulators, raloxifene is the best example. These drugs were designed to have estrogen-like effects when it's good to have estrogen-like effects, like on bone, and to have anti-estrogen effects when it's good to have anti-estrogen effects, like at the breast. And so raloxifene has clearly shown itself to be effective. This is from the original Moore trial that showed women without pre-existing fractures on the left or with pre-existing fractures on the right. You can see, by the way, the white bars are the placebo incidence of fractures, and as the point we made earlier today, if you had a previous fracture, you're going to have another one. So the incidence of vertebral fractures is much higher in those who have had a pre-existing vertebral fracture. But in both cases, you see in the yellow bars, there is a significant reduction in vertebral fractures. That is the good news. The not so good news is that raloxifene has never been shown to reduce hip fractures or other non-vertebral fractures. And this is from the Moore study that was for 3 years, but the core study, which was the extension of Moore, was an 8-year study, 3 years plus 5, and there still was no effect of raloxifene to reduce hip fracture or non-vertebral fracture. So it has a limited spectrum in terms of its skeletal effects. And then there are a lot of disadvantages, you know, about the hot flashes, leg cramps, DVT, pulmonary emboli, and stroke, just like estrogen, with the exception being that mortality associated with stroke seems to be greater with raloxifene. It's not clear why. The benefits are bone density, reducing vertebral fracture. The anti-breast effect is important, and no increase in cardiovascular risk. So if you have a patient who is at risk for breast cancer and has let me put it this way, a greater risk for a vertebral fracture, let's say the lumbar spine T-score is really low but the hip isn't too bad, raloxifene would be a great drug to use. And it has, in fact, it is being used very widely, and it's a major treatment for certain postmenopausal women with osteoporosis.
How long would you use it?
There's no time limit. We use raloxifene. I'm not super up on this, but we don't think about it as estrogen. You know, after 10 years, you better stop. So yeah, there's no proscription against that. Okay, I think we better stop here. On Wednesday, when I see you, we will try to catch up a little bit. We're not too far behind, but we always get behind.